Hey everyone, this lecture is the next in the spine series, and this is some management guidelines for treatment of different pathologies of the spine. So some of the pathologies that we're going to talk about are injuries or diseases of the intervertebral disc, the disc and facet joints, the facet joints themselves, the vertebrae, and then the surrounding muscle and soft tissue injuries. So we've talked a little bit about disc degeneration in modalities when we talked about traction. And so we talked a little bit about what discs are made of, how they work, and what can happen. So your book classifies herniation as any displacement of the disc material beyond the normal limits of the intervertebral disc space. So that is shown in figure A here. So you can see the disc is herniating here. This would probably not cause a whole lot of symptoms because it's not really pressing out on the annulus. Then we have a protrusion where the disc material is still contained by the annulus fibrosis. So again, protrusion, herniation, these terms are pretty much used interchangeably. Then we get into an extrusion where the disc material has moved beyond the posterior longitudinal ligament or above and below the disc space. You can see in this diagram in C here how the disc material, the nucleus, has now extended beyond through the annulus. So with a herniation or protrusion, we're working under the assumption that the nuclear material is still contained. A sequestration is the most severe form of a disc pathology. This is where we have extruded disc material that's no longer contained. It's separated and moved away. It's free floating. It is gone at this point. And there's really not a lot that physical therapy is going to do for a disc at this point. I included this picture down here. This is an MRI of the spine. And so you can see a little bit of herniation, a little bit of slippage here with these discs. And then here you can see a disc extrusion where you actually have disc material behind the level of the vertebrae, really, where it's actually kind of moved out, moved away from the disc. Typically when discs herniate, they just extend a little bit into the spinal canal here, like you can see between 2 and 3 and 3 and 4. But then here between 4 and 5, you've got a much larger protrusion with some actual separation of the disc material. So discs can wear down either by fatigue or there can be a traumatic rupture of a disc. So with fatigue, we're talking about the annulus just sort of wearing down over time. This is a wear and tear type of injury. It can be due to torsional stresses where the annulus starts to actually lose sort of its connection from the vertebrae above and below it, and then disc material starts to fill in those gaps. Stress with repeated forward flexion and lifting or prolonged postural stresses can start to wear down the annulus. Poor circulation in the disc is going to limit healing. So discs don't have a lot of circulation, and so when there is an injury to the disc, they're not going to heal very quickly on their own. A traumatic rupture is most likely to occur in someone between the ages of 30 and 45 because at this age, the annulus has started to break down maybe just a little bit, but the nucleus can still imbibe. We talked about that. That means taking in fluid, taking in water from the environment. Once we hit a certain age, the nucleus becomes much more fibrotic and doesn't really imbibe anymore. So as we age, we don't expect to see discs herniate quite as much. So if there is a herniation in an older person, it's most likely that it's been there for quite some time. They believe that there is some genetic link to degenerative changes. So if, mom or dad or grandparents have had a lot of spinal degeneration and problems, there is a possible genetic link with that. So some signs and symptoms of disc lesions are going to include pain because there's pressure against pain-sensitive structures like the ligaments, dura mater, blood vessels, nerve roots, or from chemical mediators. So the whole inflammatory process, it's going to irritate those free nerve endings. There's going to be local pain in that area. Another cardinal symptom of disc lesions is going to be neurologic symptoms. So when that disc herniates, it can press against nerve roots. It could also press against the spinal cord as well, depending on how large the herniation is. So if there is neurologic involvement, oftentimes we're going to see myotomal weakness and dermatomal sensory changes. So it is going to follow the myotome and dermatome patterns for the lower extremity for the lumbar spine. Another big thing is that the symptoms are going to vary quite a bit. It's going to depend on the degree and the direction of the disc protrusion or herniation. Again, as I mentioned in modalities, posterior lateral is going to be your most common, which means it's going to be putting pressure on the posterior longitudinal ligament or on nerve roots. A very large posterior lateral herniation can cause central nervous system symptoms, which typically include loss of bowel and bladder control. Those are red flag symptoms. We typically want the person to seek medical attention if they're having those types, because that's usually an indicator of a very large herniation. It's pressing on the spinal cord and can lead to other bigger problems. Discs can herniate anteriorly, although it's not very common. There'll be pain because it puts pressure on the anterior longitudinal ligament, but there will be no neurological symptoms with those because there's no nerves in the front part of the spine there. The most common levels for disc herniations are going to be L4, L5, and L5S1 in the lumbar spine. Anytime there's a disc herniation, there's going to be a local inflammatory response that can lead to fibrosis, nerve mobility impairments, and chronic pain. The typical mechanism of injury for a herniated disc is going to be bending, lifting, and twisting, so increased spinal flexion. Pain may gradually increase when the patient is not doing anything, but it's typically worse when they first get out of bed in the morning, when they first stand up, because overnight your spine is unloaded and those discs are going to imbibe or take in fluid, and then you go and you stand up and you start weight bearing on that spine, and that immediately puts pressure on that herniation again. Sitting for long periods of time can get uncomfortable. Forward bending, coughing, straining, and moving from sit to stand, because again, a lot of those positions are going to put the spine in a more flexed position. Symptoms usually improve with walking, when there's movement, but also that puts the spine in more of an extended position, which tends to take some of the pressure off of that protrusion. And again, it will often vary in intensity, again, depending on the size of the herniation and the activity that the person is doing. Clinical findings with a herniated disc in the lumbar spine, again, typically the person is going to prefer standing and walking to sitting. I've actually done evaluations on patients where I've let them stand or had them walk around the room while I've asked them questions, because I can tell that sitting is just that uncomfortable for them. They will often present with a decreased lumbar lordosis. Their spine is just more flat in the lumbar region. Forward flexion is limited, and it also causes peripheralization of symptoms. So not only is it limited, but when they bend forward or flex the lumbar spine, it causes their symptoms to get worse or to travel further down their lower extremity. Trunk extension may also be limited, but it does tend to centralize symptoms. So as they extend their trunk, their pain tends to move back towards the center or comes out of their lower extremities. There may be a lateral shift, meaning that their shoulders are sort of shifted over towards one side. That is usually a sign of them sort of shifting away from the pain or the side that's painful. I'll show you a picture of what that's going to look like. They will most likely demonstrate pain with a straight leg raise on that side. If the pain is influenced by movement, so flexion makes it worse, extension makes it better, the disc is most likely contained. So we can influence that, which is a good thing. If their pain is not influenced by movement, so it doesn't matter if we flex or we extend or we side bend, it doesn't have any effect on their pain. The disc may be completely torn, and in that case, it's going to be a little bit harder for us to have a lot of impact on that patient. In the acute stages, anti-inflammatory treatment does usually help to reduce the patient's pain and symptoms. Clinical findings with a cervical herniated disc. It's going to be very similar to the lumbar spine, but we're going to follow the cervical dermatomes and myotomes as far as sensory loss and motor loss. The patient may present with forward head, and they may side bend and rotate away from the side of pain. Just like in the lumbar spine, flexion tends to peripheralize the symptoms, meaning sends it down the upper extremity. Retractions, cervical retractions, if you're not familiar with them, they're on a slide later. They should help to centralize the patient's symptoms. So again, movement is affecting the patient's pain. They may have nerve mobility impairments. So again, this is where we will get into, could get into some of those upper extremity nerve glides, depending on what levels we have of the cervical herniations and where they're experiencing symptoms in their upper extremity. Nerve glides can be a very effective treatment for this. Manual distraction can help to centralize symptoms or relieve symptoms. This is manual traction, basically. So by distracting the vertebrae. We're taking the pressure off those herniations and helping the patient's symptoms. In very severe cases, again, very large herniations of cervical discs, you might see cervical myelopathy, which is a very serious condition. Again, this is a central nervous system problem. That means that there's a large herniation, that this is pressing on the spinal cord. And some of the characteristics of cervical myelopathy are gait abnormalities, upper motor neuron lesions, and weakness and paresthesia of the lower extremities. So again, those are not typical symptoms that we would expect with a cervical injury. So that just lends evidence to the fact that this is a pretty severe cervical injury and that person should follow up with their physician. Pathology of the zygapophyseal or the facet joints. These are synovial articulations, so these work just like all of our other synovial joints. They're enclosed by a capsule supported by ligaments. So again, they're going to respond just like any other peripheral joint to trauma, osteoarthritis, and we'll go through all of those conditions. So some common diagnosis that you might see of the facet joints are a facet sprain, spondylosis, osteoarthritis, or degenerative joint disease. Those terms are all interchangeable. So spondylosis means the same thing as osteoarthritis, which means the same thing as degenerative joint disease. It's a wearing down of the facet joints. It's arthritis of the spine. We can also have rheumatoid arthritis in the spine, ankylosing spondylitis, and facet joint impingement. So we'll go through each one of those. A facet sprain is usually precipitated by some sort of trauma, a fall, a car accident, something that happens to actually put a sprain on the facet joints and the ligaments that support them. There'll be local joint effusion, limited range of motion, local muscle guarding in the area, and there may actually be some slight swelling, which can cause foraminal stenosis and neurologic signs. So because of the swelling in this area and the close proximity to where those spinal nerves are exiting, that can put some pressure on the nerves, and there may be some neurologic signs with these as well. Typically with facet sprains, we don't expect to see neurologic symptoms. So our degenerative changes, this is going to be our spondylosis or osteoarthritis. Initially, you might see some excess movement develop, but as the osteophytes or the bone spurs start to develop between the vertebrae, you'll start to see more and more hypomobility, so more and more stiffness of the spine. Because the spine then stiffens up at those segments, we're going to see sort of compensatory hypermobility at the segments above and below. Degenerative changes like OA are going to lead to pain with movement and also make the person more vulnerable to impingement, sprains, and inflammation at those areas. Rheumatoid arthritis is more problematic in the cervical spine. Because of the increased bone erosion, we do worry about instability, especially in the cervical spine, most specifically atlanto-occipital subluxation. This is a major issue. If that ligament becomes extremely weakened, that could lead to subluxation or even dislocation, which can be fatal. So if the patient has neurologic symptoms, we want to have them checked out by their physician, x-rays, MRIs, to rule out any instabilities in the cervical spine. And just as a note, contraindication, we should never do any manipulations to the cervical spine of someone who has rheumatoid arthritis, again, because of the potential instabilities that exist there. Ankylosing spondylitis is also known as sort of the bamboo spine disease. It's a rheumatic disease. It's characterized by chronic inflammation of the ligaments of the lumbar spine, most likely the anterior longitudinal ligament, and it will actually cause a fusion of the spinal segments where it is affecting. The diagnosis peaks in the mid-20s, so it's actually a younger person that's diagnosed with this disease, and it can begin in the lumbar spine and then move from there. People who have the diagnosis of ankylosing spondylitis, the SI joints are affected nearly 100% of the time, which those joints are pretty closely fused anyway. The neck is affected 75% of the time, the lumbar spine 50%, and the hips and heels about 30% of the time. This will lead to a gradual loss of motion and make it difficult to stand up straight. The person tends to walk or stand with a more forward flexed posture. And again, with advanced cases of the disease, x-rays will reveal a bamboo spine, which is the anterior longitudinal ligament fused to the vertebral body. So it starts to look something like this here. Facet joint impingement, this is when the meniscoid or the material between the two facet joints can become extract, impinged or stressed with movement. This is typically that you slept on your neck funny and now you wake up and you can't turn your head in a certain direction. So it causes pain, causes muscle guarding, sudden onset. It can be caused by forward flexion with rotation as well. But again, it does usually lead to loss of specific motions, like I can turn my head this way, but I can't turn it this way at all. Movement is going to increase pain, especially into the limited area. But really, there's not a lot of pain at rest. There are typically no neurologic symptoms with facet joint impingement. And then the contralateral joint will become stressed over time, leading to pain. This is typically one of the things this will self-regulate. It'll start to improve on its own, given a couple hours or a couple days, usually at most. But if it continues on, you'll start to see some compensatory issues in the joint opposite. Pathology of some of the vertebrae. One could be a compression fracture due to osteoporosis. This is usually in the thoracolumbar region. Falls, trauma, forward bending, any of those things can contribute to fractures of the vertebrae. Usually occurs during the 6th or 7th decade or even later. The pain may be referred to the low back or the abdominal region, but it is also usually in the thoracic spine or the area of the fracture. We'll see an increase in the thoracic kyphosis, also known as a dogger's hump. And we do need to continue to exercise with these patients, but we need to make sure that the exercises are within their tolerance. We have talked in previous lectures about avoiding trunk flexion activities and focusing on weight-bearing activities so that we can increase the strength of those bones. Scheuermann's disease is a rare congenital or degenerative weakening of the vertebral end plates. It's typically seen in the lower thoracic or upper lumbar vertebrae, T10 through L2. And what happens is that the vertebral bodies actually become so weakened that the nucleus can protrude up into the vertebrae above it or down into the vertebrae below it. Because the vertebrae will actually become so softened or so weakened that the annulus is actually stronger than the vertebrae. And so the disc material can start to migrate above and below into the actual vertebral bodies. So there can be bony necrosis or Schmorl's nodes that form in the area. This could also be caused by insufficient blood supply to growing bone, and it does cause an increased thoracic kyphosis. So the presentation of this looks actually pretty similar to osteoporosis. However, Scheuermann's disease typically occurs in a younger population, so at an age where those patients should not be osteoporotic yet. Some of the pathologies of the surrounding muscle and soft tissue, again, just from any type of trauma or the presence of any of the other pathologies that we've previously talked about, there's going to be pain in the local area, possibly some swelling or effusion, tenderness on palpation, and the biggest thing we're going to see is muscle guarding. It's your body's protective reaction to try to immobilize that area to not let anything else happen. And so because of that, there is typically muscle guarding, which can sort of compound the pain and the symptoms that the patient is having. There can also be sluggish circulation in the area, which can irritate the free nerve endings. And again, this contributes to that pain, spasm, pain cycle. If it is a ligamentous sprain and you stress that ligament, as you would expect, there will be an increase in pain. And then there can be adaptive shortening or scar tissue adherence that happens as the person is healing. So we want to try to avoid that so that we don't have other problems or other limitations down the road. Common sites of strains in the lumbar spine are along the iliac crest because that's an attachment site for a lot of the fascia, muscles, quadratus lumborum, the erector spinae group, and the iliolumbar ligament. And that can occur with either a fall, some sort of trauma, or with repeated lifting and twisting. In the cervical spine, we can see injuries with extension-based injuries where the posterior structures are compressed and then the anterior structures are stressed. This would be almost like a whiplash injury. So this would be overextending the cervical spine. And when that happens, the mandible is pulled open, the muscles controlling jaw elevation are going to be stretched out. And then we can also see flexion-based injuries where the posterior structures of the cervical spine are going to be stretched and the anterior structures are compressed. And when you're forced into flexion of the cervical spine, the mandible is going to be forced more posteriorly, which pushes the condylar head up into the joint and can cause some TMJ issues. So with whiplash injuries, you actually see both. because whiplash injuries usually occur when someone is hit from behind in a car accident. Their head is first thrown forward, so forcible flexion, and then when the momentum is removed, it kind of snaps back into extension. So you have the stress and strain of basically all the structures in the neck. Okay, so now I'm going to get into some categories of how we can sort of classify patients who have pain, which will then lead into some treatment ideas for those patients. So one thing just to look at first is just in general, in what stage of recovery are they? Are they acute, and is there inflammation or not? Most acute injuries are going to present in the 0 to 4 week range, like most of the other things that we've talked about, and we may or may not have nerve root symptoms with that. So it's an acute, do we have neurologic symptoms with that? Subacute, we're talking more 4 to 12 weeks. Chronic is beyond 12 weeks, and chronic pain syndrome, we're talking 6 months and beyond. If someone has significant pain in their low back or their neck, we may begin with a non-weight-bearing bias treatment approach or a traction approach. And this means that the patient doesn't tolerate being upright for ADLs very well. Just even doing basic things is very painful and difficult. Movement testing makes symptoms worse. So forward flexion, extension, everything tends to make them worse. So these are the people we were kind of at a loss with. We're not really sure what to do because everything makes them worse. So traction is one thing that we can try with them. So we can start with maybe just a unilateral leg pull or a bilateral leg pull to see if that takes any tension off their back. If they show any sort of benefit with that, then we may hook them up for mechanical traction, as long as it's making their symptoms better. We can also use modalities with these patients in the acute phase to try to calm down their symptoms so that we can begin to do more with them. This slide is getting into extension bias and flexion bias, or extension-based and flexion-based exercises. This is really the McKenzie treatment approach for either cervical or lumbar back pain. And so these can be very beneficial for some patients. I've seen some patients respond really, really well to these type exercises. But if your patient doesn't fit neatly into one of these categories, go somewhere else with them to take them down another treatment path, okay? If a person is demonstrating extension bias, what that means is that really the biggest thing is that extension tests are going to decrease or centralize their symptoms. Extension makes them feel better. They may present with a flexed posture. They may present with a lateral shift. This could be due to a herniated disc. This could be due to poor posture. But again, the cardinal sign is that extension makes them feel better. So guess what we're going to do? Treat them with a whole bunch of extension-based exercises, and we're going to get into what those are here shortly. You may also have someone with a flexion bias, which means that flexion is actually going to make them feel better, and then extension usually makes them worse. So same true over here. Flexion usually makes these people worse. So it's just really the opposite. So they may also present with a flexed posture. They are more comfortable when they're flexed. Extension may make them worse. These patients would typically be those that are diagnosed with spondylosis, arthritis, stenosis, extension load injuries, or swollen facet joints. So these people like flexion. Flexion makes them feel better. This slide, this category, this one, and this one, these are all people who basically need exercise to make them better. So if someone has hypermobility of the spine, they're unstable, then they need stabilization or immobilization type exercises. This is our core strengthening, okay? So they have some sort of hypermobile spinal segment, poor stability. This could be trauma, ligamentous laxity, spondylolysis or spondylolisthesis. And again, these are our spondies. So think back to the previous slide. Spondylosis is arthritis. Spondylolysis is a fracture of the vertebral area, and spondylolisthesis is a fracture with slippage. I have some slides later that will go over these, so we'll get there. If they have muscle or soft tissue lesions, again, exercise is probably going to be the best thing for them. They may have guarded posture, increased muscle tension. This could be sprains, strains, tears, contusions, overuse. And then we have postural pain syndrome. Again, exercise and conditioning for these patients. They have poor posture. Symptoms get worse when they maintain that posture for long periods. So this could be postural strain, cervicogenic headaches, thoracic outlet syndrome, or just overall poor physical condition. So again, movement, posture correction, exercise is going to decrease their symptoms. So this is all going to be what we call a little bit later your stabilization or your immobilization treatment category. Regardless of where your person starts, if they're so bad off that they need traction to start, or they are starting in an extension-based program where extension makes them feel better, we're going to do a lot of extension exercises with them initially. Everyone is most likely going to end up in this category of stabilization and immobilization. Okay, we're going to do some core strengthening exercises with our patients at some point in their program. The last category on the slide is the opposite. This is a patient who has hypomobility of spinal segments, so they need mobilization or manipulation. This is going to be restricted mobility in one or more spinal segments, and unfortunately here in Pennsylvania, PTAs cannot do spinal mobilizations. So we'll talk about that a little bit more, but not a whole lot that you guys can do with that.